Assalamu alaikum. Good afternoon, everyone. Hello. Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. Everyone, after lunch now, the blood sugar is high, right? Okay, and today we're gonna have Fulcrum 2. It's very nice. There'll be like a battle fighting between two people, say yes and no. And we're gonna witness what happened, right? We're gonna start with the first one. Each one will be 7 minutes because we have limited time. 7 minutes each speaker. We will start first topic today. It is a Benadryl for migraine. And the first guest speaker, Dr. Ammar al-Kashmiri from Oman. He's emergency physician. He's a senior consultant in Khawla Hospital in Oman. He's Canadian board certified graduate in 2007. Also, he's have a fellowship in sport medicine. And he will come to talk about, yes, Benadryl and migraine. Please, everyone welcoming Dr. Kashmiri.
So I thought I have 15 minutes, but it turns out I have to cut down by 50%. So I'm going to skip through some of these slides. I was going to talk a bit about migraine, some management practices, and then some evidence regarding Benadryl. So I put a question mark on the yes. We'll see if it's going to be a real yes or not. So migraine, we all know it's a common disorder, very prevalent. Disabling disorder, a lot of cost to the health system. In terms of patients presenting to the emergency department, it's one of the most common reasons for ED visits, headaches in general. A lot of these are due to migraine. Interestingly, 70% of headache patients are females. What do we do when these patients come to us? How do we treat them? Current practice, we know there's a substantial variability in the treatment we use. A lot of parenteral drugs, either on their own or in combination, are used, and there's no consistent treatment, so people are not following evidence-based therapies. What are the drugs available? We have NSAIDs, dopamine antagonists like metoclopramide, ergotamines, triptans, opioids, and antihistamines. There's evidence that shows that there's variation in treatment. Opioids are inappropriately used commonly, and I'm going to just skip through some of this. We need to have standardized treatments protocols that are evidence-based and get rid of the variability. Let's talk about Benadryl. So what is Benadryl? Do you guys know what Benadryl is? So Benadryl depends which part of the world you come from, but the Benadryl we're going to talk about today is Diphenhydramine, which is an antihistamine. So you might wonder, what does histamine have to do with migraine? So we know there's an association between migraine, histamine, and allergy. And patients who have migraine are found to have elevated levels of histamine and IgE. It's a prevalent disorder in patients who have history of allergic rhinitis. And patients who have migraine have been found to have high levels of histamine during the attack. And the headache in migraineurs can be induced by infusing histamine, and that can be blocked by administering an antihistamine. So we know for sure that histamine plays a role in the pathogenesis. Not clear how exactly, probably through the vascular mechanism. Now, let's go through the evidence. So let's see if this is clinically applicable. So what studies are out there? So the study some time ago published in the Annals looked at diphenhydramine for the prevention of akathisia in patients who received prochlorperazine. This was a randomized controlled trial. So what they concluded is that diphenhydramine reduces the incidence of akathisia. However, it did increase sedation as well. Another study looked at diphenhydramine as a treatment for akathisia after it had occurred. So patients were given prochlorperazine. If they developed akathisia, they were treated with Benadryl. So it was found to be effective to reduce the signs and symptoms of acute akathisia. Going to the pediatric world, a study looked at treatments in migraine, and they found that diphenhydramine use is associated with increased rates of return, actually. So this was a negative effect. A recent study published earlier this year in the Annals looked at diphenhydramine as an adjunct to metoclopramide, again to prevent the side effects. What they found that there was no benefit in adding diphenhydramine to metoclopramide, and the rate of akathisia was comparable in both arms of the study. Did not affect the length of stay. So in conclusion, that did not really improve migraine outcomes. Just outside the context of migraine, there's some evidence maybe it does work in combination with metoclopramide. Compared to ketorolac, which is an IV NSAID, the outcome was better with a combination of metoclopramide and diphenhydramine. Again, another study showed the same positive effect with an NT of 4. So what do the guidelines say? A systematic review of the evidence was published last year by the Canadian Headache Society in Cephalalgia, and they put prochlorperazine as a first choice agent. There's no mention of any histamines as first-line agents. So in conclusion, we don't really have studies that look at antihistamines as a first choice agent. On its own, most studies looked at it as a combination, and mostly to treat side effects rather than treat the migraine as first line. So we know for sure that diphenhydramine role is to prevent akathisia and dystonic reactions. We know prochlorperazine is the first line agent, and it is associated with akathisia, so you can consider combining it with diphenhydramine to prevent the akathisia, or you could see which patients are going to develop the akathisia and then treat them. The exact percentage of patients who develop this reaction is not really well known. Some studies quote up to 1/3 of patients, but it's well below 50%. So evidence tells us combining it with metoclopramide is no use. And in the pediatric age group, again, the combination with other agents is probably not beneficial. It may have a role in other tension type headaches. So finally, Benadryl, yes or no? So who says yes? Show of hands. One person. So I actually was not convinced myself. I'm surprised I convinced you, but well, thank you, I guess.
The problem is not convinced with yes, and his belief about no. I think.
Well, that's why I said it's a yes, but with a question mark, because, yeah, I'm sorry. I made my Dr. Osama's job easier, I guess.